Actually, sir has some urgent piece of work, so I will be presenting his work on his behalf. Now, starting with this cystic fibrosis, it is a genetic condition that affects protein in the body. People which are suffering from cystic fibrosis have a faulty protein that affects the body's cell, its tissues, and the glands that make mucus and the sweat. This normal mucus is usually slippery and protects the airways, the digestive tract, and other organs and tissues. Cystic fibrosis, it causes mucus to become thick and sticky. As this mucus builds up, it can cause blockages, damages, or infection in the affected organs. This cystic fibrosis is used to cause death in childhood, and survival has improved because of medical discoveries and advances in newborn screening, medicines, nutrition, and lung transplants. Nearly 40,000 children and adults in the United States and more than 1 lakh worldwide are now living with cystic fibrosis. Children born between 2018 and 22 who have cystic fibrosis are expected to live an average of 56 years, and on average, half of the babies which are born in 2021 with cystic fibrosis are expected to reach the age of 65 or older. So in the US, because of this newborn screening, this cystic fibrosis can be diagnosed within the first month of life before the symptoms can develop. But people born before newborn screening become available may not be diagnosed until the signs and symptoms of CF shows up. The CF signs and symptoms they vary depending on the severity of the disease. Even in the same person, symptoms may worsen or improve as the time passes, and some people may not experience symptoms until their teenage years or adulthood. People who are not diagnosed until adulthood usually have milder disease and are more likely to have atypical symptoms such as recurring bouts of an inflamed pancreas, infertility, recurring pneumonia, and people with cystic fibrosis they have a higher than normal level of salt in their sweat, and parents often can taste the salt when they kiss their children. Most of the other signs and symptoms of this cystic fibrosis affect the respiratory system and the digestive system. There is no cure for the cystic fibrosis, but treatments can help control the symptoms, prevent complications, and improve the quality of life. The treatments include medicines, breathing techniques, nutritional therapies, psychological support. A combination of therapy has been used to treat the symptoms of cystic fibrosis effectively. So one of the treatment regime, that is the Dornase alpha, it is an inhaled medication that thins the mucus and used to manage and treat cystic fibrosis. It has been shown to decrease respiratory tract infections in selected patients with forced vital capacity, which is greater than 40% of the predicted. So this activity outlines the indications, actions, and contraindications for the Dornase alpha as a valuable agent in therapy for cystic fibrosis, pleural effusion, and emphysema. This Ivacaftor is a new therapeutic agent that acts at the cystic fibrosis transmembrane conductance regulated channel to alter activity. It is approved for use in patients above 6 years and older with cystic fibrosis who have at least one G551D mutation in the CFTR gene. So it is unlike that any other current pharmacologic agent for cystic fibrosis in that it specifically targets the gene defect associated with cystic fibrosis as opposed to treating resulting symptomatology. Then mucoactive agents, antibiotics, inhaled beta agonists, and the other anti-inflammatory agents that are currently the mainstay of the cystic fibrosis treatment but can be associated with several side effects in addition to cumbersome frequency of administration. Ivacaftor's oral dosing regime, it offers a more convenient treatment option. However, it is associated with significant drug-drug interactions. And several agents are used to clear the secretions from the airways of the people with cystic fibrosis. Mannitol increases mucociliary clearance, but its exact mechanism of action is still unknown. A dry powder formulation of mannitol may be more convenient and easier to use compared with the established agents which require delivery via nebulizer. The phase third trials of this inhaled dry powder mannitol for the treatment of cystic fibrosis have been completed, and it is now available in Australia and some countries in the Europe. The development of targeted therapies known as cystic fibrosis transmembrane conductance regulator modulators for cystic fibrosis has been heralded in the scientific and lay media, providing significant hope for people with cystic fibrosis. This triple combination of Alexa-Caftor, Teza-Caftor, and Ivacaftor ETI, it has demonstrated to improve lung function, weight, and quality of life in children and adults with cystic fibrosis with at least one copy of PHE 508 DEL. So, our present study, this research is based on the formulation of solid lipid nanoparticles using Ivacaftor. This Ivacaftor is a selective CFTR potentiator, which is used to treat cystic fibrosis by enhancing the function of CFTR proteins, addressing the underlying cause rather than just symptoms. It reaches peak plasma concentration within 4 hours and 99% bound to plasma proteins. With a half-life of 12 hours, ivacaftor is metabolized in the liver, producing two metabolites, M1, which is active, and another is M6. About 88% of the drug is excreted via feces, and the recommended dosage is 150 mg daily for 3 to 5 days. The basic challenges which this drug faces is due to its category of BCS class 2 classification, which is a low solubility and high permeability. This is 99% plasma protein binding and low solubility. So these factors limits its absorption and reduce the amount of active drug available in circulation. The primary research focus is on improving the solubility and bioavailability through formulation strategies while also addressing the effects of high plasma protein binding to ensure optimal therapeutic outcomes. So this solid lipid nanoparticles, these are an innovative drug delivery system which is designed to enhance the bioavailability and the therapeutic efficacy of poorly soluble drugs composed of the biodegradable and biocompatible solid lipids. And these nanoparticles are stabilized by surfactants and typically range in size from 500 to 1000 nanometers. The solid lipid core remains in a solid state at both room and body temperatures, providing controlled and sustained release of encapsulated drugs. SLNs offers several key advantages, including improved solubility of hydrophobic drugs, protection of active ingredients from environmental degradation, and a reduction in dosing frequency due to their controlled release properties. The use of physiological lipids ensures that SLNs are biocompatible, making them a safer option with minimal toxicity risks. These SLNs have broad applications in pharmaceuticals, cosmetics, nutraceuticals, and they are particularly valuable for delivering drugs with solubility challenges such as those classified under BCS class 2. With their potential for oral, topical, and intravenous drug delivery, SLNs are a promising technology for addressing many challenges in modern drug development. So the solid lipids hampered the equilibrium solubility study. Therefore, an unconventional method was required to measure the solubility of drug in the solid lipids. 10 mg of Ivacaftor was accurately weighed and it was placed in a bottle of glass. An excess amount of lipid was weighed and added to the glass bottle. Then it was put for heating to 80 degrees Celsius with continuous stirring. Additional lipid was added in separate portions until a clear solution was formed. A record was maintained to calculate the amount of lipid added until a clear solution was formed, and the solubility study for the liquid lipids and the surfactants was performed by adding an excess amount of drug to glass vials in triplicate containing each of the excipients. The glass vials were placed on a vortex mixture for 15 minutes and placed in an incubator at 37 degrees Celsius during the period of solubility study. So the vials were vortexed periodically so that the drug could be kept suspended, and samples were taken at 24 hours, 48 hours, and 72 hours so that it can reach the equilibrium. The vials were subjected to centrifugation at 37 degrees Celsius with 2800 RPM for 30 minutes, and 2 to 3 drops of supernatant were transferred in a tiered container and diluted with methanol for quantification. This solid lipid nanoparticles of this ivacaftor are prepared by emulsification ultrasonication method. The solid lipid was heated in a water bath at 80 degrees Celsius. A liquid lipid was heated separately in a water bath and brought to the same temperature. The drug was then dispersed into liquid lipid melt and stirred as it is shown in the figure. And the liquid lipid and the solid lipid were mixed at the same temperature to disperse the drug completely. Surfactant was dispersed in the aqueous phase, forming a 95% solution, and the lipid phase was mixed with the aqueous phase by bringing them to the same temperature. The mixture was subjected to high-speed homogenization at 10,000 rpm for 5 minutes at ambient temperature. The formation of primary emulsion was followed by ultrasonication with the help of probe, sonicated, keeping a constant temperature. The formed lipidic dispersion was allowed to cool at room temperature for 15 minutes to form the IVF SLN. So the results of selected response, such as particle size and encapsulation efficiency for all the experiment, was summarized in this table, and the concentration of lipid A was found to be most influential factor on the particle size. A sharp reduction in the size occurred due to the low concentration of lipid A. Its concentration also played a significant role on encapsulation efficiency, and the concentration of lipid B showed a less significant effect on the encapsulation efficiency and particle size. This is the response surface curve for the encapsulation efficiency. When the lipid A concentration was low for the formulation, an enhanced amount of lipid B was able to give a better particle size reduction. In the higher concentration of lipid A, the particle size growth was seen due to high volume. Here also a similar pattern was seen, but a reduced encapsulation efficiency was seen in response to the concentration of lipid A. This table 4 and 5, they are used to indicate the p-value for the model and proves that the selected model was significant. The model design was validated by analyzing the checkpoint batches, and one of the checkpoint batch was carefully selected to be accepted as an optimized batch. This figure shows the FTIR curve for the pure drug, and this another, which is in the blue, shows the FTIR curve for the optimized formulation. The spectra show the main features assigned to the constituent as reported in the literature. The state could be associated with changes in the secondary structure. The DSC curve, the pure Ivacaftor, and the formulation is also shown in the figures. The pure drug shows sharp melting point endotherm. However, the endothermic peak of IVF formulation was absent, which confirms the amorphous state of the formulation. The nanoemulsion optimized batch showed the zeta potential values of minus 33.7 plus minus 0.56 millivolts, and the value of zeta potential was a negative scale, which was indicative of its anionic formulation. IVF, SLN, and marketed formulation in rats after the oral administration is presented in the graph, and associated pharmacokinetic parameters also. In comparison with marketed formulation, it exhibited significantly enhancement in oral bioavailability, which was revealed by the increased Cmax and AUC. Our formulation showed faster Tmax, indicating rapid and high absorption. And the enhanced oral bioavailability of IVF-SLN is due to the increased dissolution rate. So this was all about our research. I'm open to questions if there are any. Thank you.